Well, good afternoon. My name is Chris Sorrell. I'm one of the senior portfolio managers at Probity Advisors, and I'd like to thank you for coming to our 2012 Winners Luncheon Speaker Series. It's great to see so many familiar faces in the crowd this afternoon. I really thank you all for being here. And I'd like to extend a special thank you to John Goodman and the NCPA for being our keynote speaker this afternoon. For those of you that are not familiar with the NCPA, it stands for the National Center for Policy Analysis. It's an independent research organization and bipartisan think tank that specializes in bringing free market theories to the legislative debate inside Washington, D.C. While you may not be familiar with the NCPA by name, you're going to be very familiar with a number of their legislative victories, which include the Roth IRA, health savings accounts, qualified default investment options within 401ks, and a variety of Social Security, healthcare, and entitlement reform initiatives. I've heard John speak on a number of different occasions, and I'm always impressed by his ability to take the complex policy debate and to be able to distill it into a dialogue that's both entertaining and educational at the same time. And I think you're going to really enjoy what he has to say this afternoon. But before I turn it over to John, I thought I'd take a step back and discuss why we're talking about policy today. Typically, you'd expect a money manager to want to talk about maybe the 2011 year in review, maybe give you a forecast for 2012. But the fact of the matter is we can't really separate the discussion of how our financial markets are and how the health of the financial markets will continue without discussing the public policy debate. How we address healthcare, how we address entitlement reform, how we address our debt become a major influence on our financial markets going forward. And that's particularly true given the major demographic shift that we're seeing take place not only domestically but internationally. And so for my part today, what I want to impress upon you is the magnitude in the moment. The magnitude in the moment of the demographic shift that we're seeing. Then I'm going to hand it over to John to talk about how this wave of demographic shift will impact our current institutions, our current policies, what the legislative chessboard looks like, and he'll introduce us to some of the ideas that the NCPA has for solving these problems. Lastly, we're going to follow all this up with a webcast and a series of discussions online where we'll talk about our asset management strategies, our financial and estate strategies for resolving these issues and how we're going to implement these for our clients. So let me get started by talking about demographics, because this is what drives this whole problem, whether we're talking about Europe or whether we're talking about the United States. And so I struggled with a way of trying to make demographics engaging and entertaining. That's not, economics is known as the dismal science. And, I don't understand that everybody's on their lunch hour today, so I'm going to try to make this as entertaining as I can. But what we have here, in an effort to try to make it entertaining, I started doing some research on demographics, and I came across a gentleman by the name of Hans Rosling, and he did a presentation before the TED Institute where he did a time series analysis and animated it. And so I don't want to drag you through every detail of these statistics. What I want to try to help you with is just to understand, again, the magnitude and the moment of where we are in this demographic shift. And so while Hans Rosling applied his theory to birth rates and family size, I've taken his technique, but I'm applying it to something called a dependency ratio. Okay, and so I'm just going to set this slide up. Obviously, it's called Worldwide Demographic Shifts from 1950 to 2050. And we happen to be at 1950 right now. And I've plotted a bunch of different countries on this graph. The one we're going to be most interested in is obviously the United States, because this discussion really is about our domestic policies. But you can't really divorce the conversation about demographic shift from what's happening worldwide. I mean, the issues we're seeing in Europe right now are largely a function of promises that were made and a massive shift in their demographics. And so I've gone ahead, just for reference point, put a bunch of different countries that we're familiar with. So each dot represents a country. I did aggregate Europe as a group, so you'll see that we have regions down here, and it's color-coded to the country. And the size of the dot is their relative population size. And again, in 1950, what I'm measuring on the x-axis is the percentage of the population that's of workforce age, so age 20 to 64. And so the great thing about a workforce is that it's very, very good for your economy. Right? You get a twofer out of a workforce. You have people that are producing things. Those goods are being sold. That's creating sales for companies. That's creating profits. That's creating wealth. It's being taxed. It's helping your government. At the same time, the worker is also earning wages and is consuming goods at the same time. So it's a twofer. And so we're going to consider this area over here to be a very favorable economic growth area. And what you see in 1950, we have low percentage, and what I have on the x-axis here is the percentage of the population that's over age 65. And so in 1950, we didn't have a lot of people as a percentage of our overall populations that were over the age of 65. And so it's kind of flat, and people are generally have a high percentage of their workforce, of their population of workforce age. And so what I'm just going to do, and so from here, we know that the workforce is obviously good for our economic condition. On the y-axis, we have the percentage of the population that's of retirement age. And when you have an unfunded pension liability system like we have in the United States, where you rely upon the current workers to provide for the benefits that you've promised to the retirees, obviously the less workers and the higher the retirees, the more stress that puts on our public systems. And that's at the heart of the problem that we have today, is that our demographics are shifting. We have more retirees per worker. And in 1950, the United States had essentially 7% of their population was of 65 years and above, yet we had 58% of our population of workforce age. And so what I want to show you is, as the baby boomers are born, as they enter the workforce and Generation X follows on their tail, you'll see a massive expansion of our workforce. It coincides with the booms of the 80s, it coincides with the booms of the 90s, and it forces us out into this very favorable economic growth area. But then you're going to see a moment at which this all shifts and we start to move back the other direction. And that's all I'm trying to impress upon you today, is that there's a moment that's before us right now that will have major implications on our financial markets and our public sector going forward. So let me just kind of animate this for you. We're going to go from 1950 to 2050. So we get the baby boomers being born, they start to pull down. We see an expansion of our workforce. And you see a moment where it starts to shift and we move back into the less economically favorable region. And so, as you might imagine, we see some familiar countries up here. We see, again, this is projected out to 2050, but Italy and Greece start to lead the pack pretty quickly. And so you can see the pressures they're already beginning to experience. Fortunately, the United States is a little better off, but we have a threefold increase in the percentage of our population that's age 65 and above. So we go from a situation where we essentially had 5 or 6 workers per retiree. Now we're going to a situation where we have 2 to 3 workers per retiree. And that lays at the heart of the problem we face today. So this is all interesting. And it's obviously what I'm trying to stress to you today, but there's another way of looking at this as well. So over the last 50 years, what I'm basically telling you is we've had a very favorable economic and demographic condition, which is the expansion of that workforce. So let's look at how we've been spending our federal dollars underneath this favorable situation. So in this slide, and this is my last slide, this is our percentage and allocation of federal spending from 1950 to 2015. John will pick up with this and expand upon this. But what I want to show you is, in 1950, we're on the cusp of the Korean War. We just come off World War II. We're spending a lot of our money on defense, and I'm not making a value assessment of where we ought to be spending our money. I'm just trying to point out where we were spending our money. And 4 categories made up about 20% of our federal budget: welfare, pensions, healthcare, and interest on our debt. And under favorable conditions from basically the last 65 years, where we have very favorable demographic conditions, these areas have grown to now make up over 65% of our federal budget. And that's prior to this demographic wave that's going to be upon us. And so my only point today is that you take this, you look at our current debt situation, you look at the demographic wave that's upon us, and something's going to have to change, right? And we want things to change in a way that are pro-market versus contrary to the market's goals. And that's where the NCPA comes in today, and that's where John's going to pick up and expand upon these ideas this afternoon. So I thank everybody for their attention this afternoon. I'm going to hand it over to John to tell us a little bit more about the condition that we're in. Thank you very much.
Thank you, Chris, and good afternoon, ladies and gentlemen. If you Google the John Goodman Health Policy blog, you're going to discover 2 things. First of all, it is the only health policy blog that's right of center. And by that all I mean is it's the only health policy blog where all the bloggers believe that economic incentives matter, and that the reason we're having so many problems in healthcare is because we're giving people perverse incentives. And the second thing you're going to discover is it's the only health policy blog of any political persuasion that has a sense of humor. I don't know what it is about the field that I'm in, but we got a lot of sourpusses. And not only do they not have a sense of humor, they don't always know when I'm joking. It's gotten me in trouble, so we developed this little yield sign, which is a humor alert sign for the humor challenge. And so when we think we're being too subtle, we put that up so people like Paul Krugman at the New York Times will know, hey, don't take this totally seriously. We feel like if we can't make you smile at least once a day, we're not doing our job. We do things like, we had a post the other day about how Obamacare is going to push most of you into an HMO, and they may be rationing your care. And we had Aretha Franklin there from YouTube singing Say a Little Prayer for You. And then we had a post the other day on end-of-life care, and we had Bob Dylan singing Knocking on Heaven's Door. We had a great exchange the other day with the insurance companies arguing with the doctors, and it just went back and forth forever, it seemed like. And one doctor finally said, you know, your insurance guys are killing our patients with all your rules. And I thought, well, that was classic. So underneath that one, I had Leslie Gore singing You'd Cry Too if it happened to you. You know, occasionally we've been accused of being insensitive and a little bit irreverent, and maybe the worst thing we ever did happened a couple of years ago. Some of you may remember this man down at Parkland Hospital emergency room. He goes in, he waits 19 hours and dies before he ever saw a doctor. We thought that was tragic. We thought that probably happens in other parts of the country as well, so we just had a comment on it. But underneath the comment, we had Lionel Richie singing All Night Long, and that probably wasn't as sensitive as we should have been. I'm going to talk a little bit about health care today because, as I'm going to show you in a minute, our budget problems are really at base health care problems. But let me just say, just for a moment, about what we do as an organization. The National Center for Policy Analysis is a think tank. And we work with some of the best and brightest scholars all over the country on some of our nation's most difficult public policy problems. And increasingly, the most difficult problems are the social insurance problems, the problems that relate to retirement and health care and disability and unemployment. Now, the reason we got big government in the 20th century was mainly government providing social insurance to the middle class against risks that were very hard for them to insure against in the private marketplace. For our 28 years of existence, we have focused on a lot of things, but we've devoted special attention to all these social insurance issues. Not only are they the reason that government grew in the 20th century, but it's really hard to undo it. I mean, I can tell you right now in the world today, there are about 30 countries that have completely or partially privatized their Social Security system, and all that's good. But there's not a single country in the world that's privatized a healthcare system. So healthcare is really hard. Disability is hard. Unemployment insurance is hard. So we're dealing with really hard issues. Now, for the macroeconomic questions I know you all are interested in, let me just start by saying this, that the United States is the only country in the world today that can have a debt equal to 100% of its gross domestic product. They can have a deficit equal to 10% of its gross domestic product and go out in the world capital markets and borrow money at almost 0% interest. You know, no other country can do that. But let me tell you the bad news. This is coming to a close. And let me just show you a graphic that will tell you why we can't do this forever. The blue lines on this graph are the percent of income taxes that we needed in 2006 to pay for all the government spending. The red bars on this graph are the percent of your income that we're going to need at mid-century to pay for all the various government spending programs, assuming we just continue on the path we're on right now. So we just keep doing what we're doing. We don't abolish a single program. We'll get out there and with very high tax rates. And in fact, this graph says that by mid-century, we're going to need 2/3 of the income of an average income family. And for people like you, we're going to need 92% of your income. Now, this assumes that we can actually collect 92% of your income. In fact, we never will get that much money because, remember the Laffer curve. People in the face of high tax rates do things to avoid and evade taxes and reorganize their lives. So we'll never get money like this, but it gives you some idea of the size of the problem. Now, where did this graph come from? Is this some right-wing critic of government that did this? No, this graph came from Peter Orszag when he was head of the Congressional Budget Office. Peter Orszag, you remember, then became President Obama's chief economic guy. And this is a graph that he prepared before he left the Congressional Budget Office. He also prepared this graph. This one shows what happens if we actually succeed with some of the reforms that you and I are going to talk about in just a moment. We managed to slow down the growth of these programs modestly, but even with the kind of reforms that people are talking about, we'll still get out to mid-century and we'll need 60% of your income. Again, this is a tax rate that I don't think is collectible. I don't think we can get that much of your income. So we're on a dire course, and it's a course, if we continue on it, we will not be able to continue to borrow in world capital markets at near zero interest rate. Now, here's a graph that is going to kind of remind you of a college seminar of some sort. So I got a lot of lines up there, but all this are the different parts of the federal budget and showing how they go out through time, and it's showing them as a percent of GDP. And what this graph shows is that the discretionary spending goes down and levels off. The mandatory spending goes down and levels off. Social Security rises a little bit, but then it levels off. The green line, that's our problem. The green line is the healthcare line. It's the one going uphill. The green line is the reason we have a deficit spending problem. Our deficit problem is fundamentally a healthcare problem. And this graph, by the way, assumes that Obamacare slows everything down the way I'm going to show you in just a moment. If Obamacare doesn't slow everything down, and most of us think it won't, then the green line would be even steeper and this graph would look even worse. This graph has us going out to mid-century, and healthcare is half the government budget. The worst case scenario is we get out to mid-century and healthcare is the entire government budget. This graph shows the unfunded liability in Social Security and Medicare. The red parts, that's Medicare. The blue is Social Security. And what's an unfunded liability? Unfunded liability is the promises we have made by law to people this year, next year, going indefinitely into the future, minus what we expect to collect from them in the form of dedicated taxes, payroll taxes, and premiums. Okay? It's what we promise versus what we're going to get. And there's a huge gap. And why is there a huge gap? Because we have, like most other countries in the world, we run our entitlement programs like Ponzi schemes. Right? We run these programs the way Bernie Madoff ran his fund. Right? I mean, we take money in and we spend it. And we spend it the very minute, the very hour, the very day that it comes in the door. We don't save anything. We don't invest anything. Payroll taxes are spent. If they're not spent on the programs that they're supposed to fund, we spend them on something else. But we don't save them. There's no cash being salted away in a bank vault somewhere. It's all being spent. Now, if you look at this graph, I want you to look at the high bar on the left, because that's where I think we are, and it shows that the total unfunded liability is about $107 trillion. Just to put that in perspective, that's about 7 times the size of the whole economy. So what that's saying is that we have made promises over and above any income to fund those promises, and the difference is equal to 7 times our entire national income. If Social Security and Medicare were funded, if they were sound, we would have $107 trillion in the bank right now earning interest. We don't, in fact, have anything in the bank earning interest, and that's why we have a big problem. That's why on the previous graph you see that green line going uphill, taking more and more of the budget with each passing year. Now, one other thing I want to point out to you about the bar on the left, and that is that Medicare is about 6 times the problem of Social Security. When George W. Bush was president, He tried to privatize Social Security, and I helped him. I actually went out on the road with some of the Bush people and tried to sell what the president was trying to do. And we failed at that. But what I want to draw your attention to is that the problem we were talking about is small relative to the Medicare problem, which is huge. And basically, if we didn't have a health care problem, we could muddle through on Social Security. I mean, we could tinker with it here and tinker with there and get rid of it. We cannot muddle through with Social Security plus Medicare plus Medicaid plus other health care. Okay. That's going to kill us. All right, one more point to make about the bar on the left. This is the present value of unfunded liability looking indefinitely into the future. All right? So you might wonder, well, okay, how much do we owe, though, right now, as of this very minute? I mean, suppose we close the whole program down. What is the size of the benefits people have already earned? You know, the way a private pension has to account for its assets and liabilities is the accountants ask, well, what if we close down this pension today? What if we didn't collect another dime from the worker? We didn't allow them to accrue any more benefits. What do we owe today? Well, what if we applied that same test to Social Security and Medicare? How much of that $107 trillion have people already earned? And the answer is about $52 trillion. About half of it has already been earned. And $52 trillion is what? It's more than 3 times the size of the whole economy. So I just want to point this out so you'll understand it's not easy to get out of this. In fact, we're not going to get out of it without in some way taking away from people things that we've already promised to them. All right? Now, as an example of taking away what's already been promised, I want you to look at the bar on the right. That bar on the left, that's $107 trillion unfunded liability, was reported by the Social Security and Medicare trustees in 2009. The next year, the very next year, in 2010, they said now the unfunded liability is down to $55 trillion, almost cut in half. Medicare more than cut in half. That's a huge, huge change. In fact, I've never seen anything like a change like this just totally ignored in the financial press. I don't know, you all can tell me if you've heard this before. You can go to the trustees' reports, you can see the numbers, but I never see this talked about other than an editorial that I and my colleagues would write for the Wall Street Journal, but aside from us, people have just basically ignored this. You would think the Obama people would be encouraging people to celebrate this huge accomplishment. What, by the way, happened between 2009 and 2010? What happened to cause that huge drop? Does anybody know?
Affordable care.
Obamacare. Just to try to jog your memory a minute, for the next 10 years, Obamacare is going to spend, what, $1 trillion? Okay. And of that $1 trillion, how is it going to be funded? More than half is coming from Medicare. You've probably heard that. More than $500 billion over 10 years, but it doesn't stop after 10 years. It keeps on going, for the next 10 years and 10 years after that. That is the reduction in Medicare spending that's embedded in this legislation. And is it taking away benefits that have been promised? Yes, it is. But how is it doing it? Well, the way the legislation is worded is the federal government is going to try to get more efficient. You've heard that before, right? And we're going to do pilot programs, and we're going to do this, and we're going to do that. But at the end of the day, somebody had the bright understanding that it might not succeed. And so if it doesn't succeed, then what are they going to do? Then they have a commission that's empowered to reduce fees to doctors and hospitals. And that's really what's going on here. Pay the Medicare doctor less. Pay the hospital that provides Medicare services less. The problem with that is that we keep ratcheting down what Medicare pays, but the healthcare system itself isn't changed at all. So costs keep rising just as fast as they have been rising. I'll show you that in just a moment. So what you're spending on seniors falls further and further behind what everybody else is paying their doctor. In fact, the Medicare actuary says before this decade is out, if we follow the path here, that Medicare will be paying less than Medicaid. Medicaid for poor people. Now, all of you probably know if you're on Medicaid, they promise you the moon. There's almost nothing Medicaid doesn't cover, The only problem is you can't find a doctor who will give it to you. Right? So what happens here in Dallas? The Medicaid folks either go down to Parkland Hospital and wait maybe not 19 hours, but the average wait down there is 6, 7, 8 hours, unless you're bleeding all over the floor. And if they don't go to Parkland, they go to community health centers. But it is not easy to see a doctor. And the reason I'm telling you this is because most people inside the Washington Beltway don't think this will ever happen. They think that when seniors can't find a doctor who will see them, they'll be on the phone with their congressman. And the pressure will be so great they'll just undo it. And why do people think that's going to happen? Because it already has happened with the doctors under a previous Medicare law. It was back in about 2003, we passed the Medicare prescription drug program, and one of the ways they paid for that was they said, okay, we're going to let doctor fees grow no faster than the economy as a whole. And that went on for 1 year, and Congress said, oh, no, we can't do that. And so they put off the cuts, and they put it off 9 times. 9 times Congress has said, no, we can't do this. The seniors won't be able to see doctors. Well, if they've done it 9 times already, what makes you think they're going to allow these very severe cuts to go forward? What do they look like? Suppose they did go forward. What are we really talking about? We're talking about for a 65-year-old losing about $35,000, $36,000 of spending. That's about 3 years of Medicare benefits. It's not a trivial amount. The next bar is a 45-year-old. He's going to lose $60,000+ of spending. That's about 5 years of Medicare benefits. And the 45-year-old, which is the far bar over there, he loses more than $100,000, and that's about 9 years of Medicare benefits. To put this in perspective, suppose we tried to reduce Medicare spending not this way, but another way that people talk about a lot, and that is raising the age that you have to reach before you become eligible. So for the 65-year-old, this is like raising the age of eligibility from 65 to 68. And for the 55-year-old, it's like raising his age of eligibility from 65 to 70. And for the 45-year-old, going all the way up to 74. That is the magnitude of spending reduction that we're talking about. And if it takes place, a lot of people are going to get, either they're going to have to come up with extra money out of their own pocket, or they're not going to get a lot of care that they thought they were going to get. So, and the sad thing about all of this is no one's talking about it. Certainly the Obama administration is not talking about it. And the problem with the healthcare media, and I deal with them all the time, I hope no one is in the room that's from the healthcare media, these guys don't know anything. They think healthcare policy is about healthcare. They don't understand it's about money. And the minute you start talking about money, the eyes glaze over, and they can't follow what's going on. So none of this is being well reported. Most financial reporters don't understand healthcare, and the healthcare people don't understand dollars and cents. So that's where we are. All right, now I'm going to show you another graph, and again, you're going to think you're back in some high college seminar or something, but I'm going to use this graph to explain something to you that I suspect has never been well explained to you in any newspaper article, and probably not in anything you ever received from any investment service. But I want you to look at that top line. That top line is Medicare growing through time. And the whole healthcare system, by the way, is growing at the same rate of growth as Medicare. So when I talk about Medicare, you can envision that the whole healthcare system is going through the same thing. Basically, for the last 40 years, our economy has been growing at 2% real growth per year per person, okay? So our gross domestic product for a long, long time has been growing in real terms 2% per person per year. Healthcare for the last 4 decades has been growing at 4% per person per year, again in real terms, okay? So there are 2 ways to describe this. What we're spending on healthcare has been growing twice as fast as our income, or the way they typically say it in Washington, healthcare has been growing at the rate of growth of GDP plus 2 more percentage points, all right? And that's that top line. Now, you do not have to be an accountant, or an economist. You don't even need a pocket calculator to know that if you're buying something and its cost is growing at twice the rate of growth as your income, that it's going to be crowding out other things you're consuming, right? You don't have to think about that for very long. And in fact, if we stay on the course that we're now on, we're going to get out to mid-century, and healthcare will have crowded out everything else you're consuming. I mean, today's college students, if we stay on the path we're on, today's college students will reach the retirement age, and they'll have nothing to eat, nothing to wear, no place to live, but they're going to have really great health care. All right? That's where we are. That's the blue line, and we call that unsustainable because that can't go on forever, right? Eventually we run out of everything else that we have to have. Okay, now what is the red line? The red line, those are all the reform plans. Some of you may remember, one thing I used to like about Barack Obama was he stood out from the other candidates in the Democratic primary. He was the one candidate who said, we are going to have to do something about Social Security and Medicare and Medicaid. And the New York Times beat up on him, and Paul Krugman, the New York Times editorialist, criticized him for that, and other people on the left wing of his party criticized him for that. But he stuck to his guns, and he gets elected. And then he appoints what, the Obama Deficit Commission, what some people call the Bowles-Simpson Commission. That's Erskine Bowles, who was Clinton's chief of staff, and Alan Simpson, the Republican senator, former senator from where? Wyoming, I think. And by the way, I had those two guys in Dallas last year. I interviewed them. We got on C-SPAN. They're really great. And I'm going to tell you something they told me in just a moment. But Obama appoints this commission. Congress didn't want him to do it. The Republicans even said, we don't want it either. He stuck to his guns, so he told Simpson Bowles, you go tell us what we need to do. I'll back you. And sadly, he did not. We rolling around a year. The report comes out. The White House says nothing. This is in fall of last year. We get a State of the Union speech, nothing. We get a budget from the White House, nothing. We go in the spring, the Republicans start pointing to the report and say, hey, there's a lot of good stuff in there that we ought to do. The White House starts attacking the Republicans. So I was very, very disappointed to see that, because I believe that just as it took Nixon to go to China, it took a Republican to change what we were doing in foreign policy. I believe it takes a Democrat to do what we're doing with entitlements programs. So very hard for a Republican to do it. Bush got nowhere. Erskine Bowles told me off the record something that I long suspected, and that was that Clinton was going to do some pretty radical things. They had plans to create private accounts in Social Security. They had plans to create vouchers for Medicare. And you know what stopped it all? Monica Lewinsky. Yeah. I mean, once Monica comes along, that was a very expensive little tryst with her. Once she came along, the left wing of the Democratic Party and the Congress said, hey, we're not going to back you unless you drop all these radical ideas, which they proceeded to do. So there have been two real disappointments here, first with Clinton and then with Obama. But in any event, the red line represents the reform plans. Okay? And not only is there a Simpson-Bowles plan, but there is a Rivlin-Ryan, Alice Rivlin, former Democratic head of the Congressional Budget Office, Paul Ryan, the conservative Republican in the House, is the budget guy. Then there is a Domenici, Rivlin Domenici is a Republican. Now, more recently, there is a Ryan Wyden. Wyden is the liberal Democrat from Oregon. All these plans say, hey, we've got to control Medicare, and all of them has as their goal the rate of growth of GDP plus 1% instead of 2%. But I just want to point out two things. One, even if they achieved all of this, they still have health care growing at 1.5 times your income. And that's not sustainable either. The second thing I want you to know is when Alan Simpson and Erskine Bowles were down here in Dallas and they said this to the C-SPAN audience, we don't have a plan. We have a line on a graph. Right? I had a blog post about all this and I titled it, My Line is Lower Than Your Line. Because, folks, that's really all it is. None of these guys have a plan. I like Paul Ryan, but he doesn't have a plan either. It's just lines on a graph. And Simpson said, we need the NCPA. We need you guys to tell us how to do this. That's just for us to go. All right, now I want you to look at the light blue line. The light blue line is, according to the Medicare trustees, what is embedded in the Obamacare legislation. And I will warn you, it's a little different from what the Congressional Budget Office says is going to happen. But the Medicare trustees are all appointed by the President. That's the Secretary of Treasury, Secretary of Labor, some other secretaries. They're all Obama appointees. So we view the trustees' report as the administration's view of its own health plan. Okay? And this is what their view is, that Medicare spending will grow no faster than national income. Now, if they do that, our problem is solved. Right? If Medicare is not growing any faster, and by the way, they're going to do the same thing with Medicaid. So if the federal spending on health care grows no faster than our income, we don't have this big budget problem anymore. The problem is, in order to make that happen, you keep squeezing doctors and hospitals, and pretty soon these folks don't get health care. And they don't have any realistic plan to deal with that. I want to draw your attention to the purple line. You know, about a year ago, Paul Ryan asked me to come to Washington and meet with him. And I met with him and Eric Cantor, and there were a few other people in the room. And they said, we want to know what you think we should be doing. And I said, well, let's just take stock of where we are right now. We have the Obama folks that have committed to that light blue line. Okay? And if they stay on that light blue line, the seniors are going to get creamed. And the seniors may not understand all of this, but they somehow sense they're going to get creamed. And they went out in the last election and they voted the other side out of office. I mean, the reason for the election results of the last election, the reason Democrats lost the House of Representatives and lost a lot of Senate seats too, was because of senior citizens switching from Democrat to Republican. Okay, so this is not just, pie in the sky budget numbers. This has serious electoral consequences. So what I said to Ryan is, do whatever you want to do, but don't get below their line, because this is, when your enemy is shooting himself in the foot, you don't want to get between the bullet and the foot, right? So Ryan says to me, but look, we can't come out with a budget that's more liberal than the Obama budget. And I said, why not? Anyway, they did come out with a budget that pretty well follows Obamacare for the next 10 years or so. And then it goes downhill. So basically, the Ryan House Republican budget, which all the Republicans in the House voted for, they voted to have Medicare grow no faster than the consumer price index. Okay, so you have people now voting for stuff that could not possibly ever happen, and I don't understand why. Because on both sides, I mean, they're just setting themselves up to be creamed by voters, because none of this is ever going to happen. As for differences between the two parties, for anybody over 55 years of age, there's no difference in what the Democrats voted for when they voted for Obamacare and what the Republicans voted for when they voted for the Ryan budget. They all voted for the same thing. And they all voted for something that is not going to happen. Let me do one more thing with you. When you talk about these numbers and you make these projections, remember what Yogi Berra said about predictions? They're unreliable, especially when they're about their future. But here is how, the reality is going to make itself known to people in Washington. With each passing year, the deficit in Social Security and Medicare is going to require more and more funding. And where is that funding coming from? It's going to come from the general revenues that they collect from the rest of us, right? Because the payroll tax isn't enough to pay for all of this. And so with each passing year, the federal government's going to need more and more of general revenues that come its door, which means if we don't raise tax rates, we're going to stop doing a lot of other things we're doing. And in fact, what this chart shows is that we're going to get out in just 8 more years, and we're going to need a fourth of all general income tax revenues to make up for these deficits. And one way to think of that is that the federal government in just 8 years, if it wants to balance its budget, is going to have to stop doing 1 out of every 4 other things it's doing. right? It's highways, education, defense, whatever it is. It's going to have to stop doing 1 out of every 4 things it's doing. By 2030, it's going to have to stop doing 1 out of every 2 other things it's doing. So this is not an abstract problem. It's going to impinge on every other program, just as Medicaid at the state level impinges on everything else the state governments are doing. That is our financial problem looking forward. Let me just say a word about our organization, and I'm going to open it up. We try to identify the best folks to deal with problems like this, and we think that they've done a really good job in figuring out ways to privatize Medicare, privatize Social Security, move to a system in which each generation is saving and paying its own way. We've already had some accomplishments that Chris alluded to. Because of our idea of health savings accounts, there are now 23 million people who are managing some of their own health care dollars, and that's the fastest growing product in the health insurance marketplace. Because of our idea of the Roth IRA, there's now $250 billion in the stock market, in bonds, and that money will never be taxed again. Because of another NCPA idea, the 78 million baby boomers will be able to reach the retirement age, and they will be able to keep on working and not lose Social Security benefits. Even ARP didn't support that. That was really a homegrown NCPA idea. And I'll tell you one more accomplishment, and we did this with Brookings, and we did it when Peter Orszag was at Brookings. NCPA and Brookings coming together to reform the 401k system, so that now employers can automatically enroll their employees in a 401k plan, automatically put them in a diversified portfolio. The employee can go get out if he wants to, but he starts out at the right place, and most people will stay wherever you put them, by the way. And we think that was a very important reform because it's going to mean for the future people will have safer returns and bigger returns than they would have had. You all have been a very attentive audience. I appreciate it very much. I'm going to open up for questions, but thank you. Okay, I saw some hand. Yes, sir. Yeah.
So it seems like the underlying problem we have here is the cost of health care, regardless of whether the government's paying for it or not paying. How do we solve that?
Well, I'm sorry to say that Republicans don't understand this any better than Democrats. The people in Washington do not understand why they have a problem. We have a problem for the same reason all the other developed countries have a problem. And one thing I forgot to say is that our trend is not worse than other countries. In fact, we're right in the middle of the European average. And all around the developed world, we have so suppressed market forces that markets aren't functioning in healthcare anymore. All right? No one ever sees a real price for anything. No employee ever sees a real price for health insurance. You as a patient, you never see a real price for care. If you're a doctor, you never get a real price for care. And so we have a system in which people basically are out there spending other people's money. And you'd be surprised how much of your money I can spend on medical care, even if I'm not sick. I believe we could spend the whole GDP on health care without ever treating a single disease. That's on the demand side. Now, on the supply side, if you're a doctor, you're a hospital, you're any kind of provider, you know people aren't spending their own money. And so you're not going to compete for their business on price, right? And when the doctor doesn't compete on price, he doesn't compete on quality either, by the way. So everybody has got a perverse incentive. I've got a whole book coming out on this, and it's called Trapped. And the reason for the title Trapped is because everybody is trapped in a perverse system, and they've got perverse incentives. And if we want to get out of the trap, we have to liberate the doctor, liberate the patient, and give them good incentives. Yes, sir. Okay, let me respond to you. I think a lot of interesting things are going out there. A lot of employers are doing interesting things. A lot of insurance companies are doing things. I don't have a lot of hope that people on the demand side of the market can solve this problem. I believe the problem is going to be solved, has to be solved on the supply side. And just to take your idea that, we've got these chronic conditions. I mean, our most expensive patients are patients that have a lot of comorbidities, like 5 or 6 comorbidities. That's a fancy way of saying they got a lot of stuff going wrong at once. And there was an article in Dallas News just last week that talked about one of the doctors here in our area. And he says, a patient comes to me with 4 or 5 problems, I can really only treat one of them. Well, why is that? Well, because Medicare will only pay full price for me treating one disease per visit. I go on to, if I treat the diabetes, if I go on to the hypertension or the high blood pressure, I don't get full payment. If I'm a specialist, I get half price for that. If I'm a primary care physician, I get nothing for that. And so I do one treatment per visit, and then they reschedule or go see somebody else. So we've got a totally fragmented system in which we have given the doctor horrible incentives. I believe we need to liberate doctors. And I don't want somebody to find the answer on how to treat diabetes, because there will never reach that point. There will always be a better way. Liberation means the doctor ought to be able to go to Medicare and say, look, I can do this a better way. I want to be paid a different way. I'm going to give you one example. I think this is so interesting. Dr. Jeffrey Brenner, up in Camden, New Jersey, one of the poorest places in the whole country. And Brenner is an altruist. I mean, he's not out for money. And he goes to the hospital records and he figures out that 1% of all the people living in Camden are spending 30% of the hospital's money. He finds one guy who's really a disaster. This guy weighs more than 600 pounds. He's an alcoholic. He's a drug addict. He spends half the year in the hospital. And when he's not in the hospital, he's just totally abusing himself. So Brenner finds this guy. He gets him to clean up his act. He gets him enrolled in Alcoholics Anonymous. He gets him going to church. And before long, the medical bills start going down. And that works so well, he forms this group, and they start doing it with more people. Brenner tells me he can go down the street of Camden and point to whole buildings and tell you how much that building is costing Medicare and Medicaid. So by focusing on the patients with the most expensive problems and treating what he's really doing is social work, he's saving Medicare and Medicaid millions of dollars. Okay? Now, how much do you think Medicare pays Dr. Brenner for saving it millions of dollars? Zero. How much does Medicaid pay him for saving it millions of dollars? Again, zero. Why is that? Well, Medicare has this list of 7,500 tasks it pays for. It lists each task separately. If you're not on the list, you don't get paid. Social work isn't on the list. So we've got a system in which the people who figure out the right way to do things can't get rewarded. So right now, Brenner is up there thinking, well, how can I fit into the new Obamacare scheme? That is not what we want him to be thinking about. We want the Medicare to say, well, Brenner, if you save us $1, you get to keep 25 cents. We want you to get rich. And why do we want you to get rich? Because we want people all over the country to know that they can get rich too if they save the taxpayer money. That's sort of our approach at the NCPA.
Would the NCPA be in favor of expanded use of health savings accounts perhaps to anyone?
Absolutely. There are a bunch of silly rules, and as you probably know, there are different accounts. There's also the health reimbursement arrangement. We've got the flexible spending account. You've got all these silly requirements, all these silly rules. This ought to be easy. You have third-party insurance and you have self-insurance. Self-insurance means you put money in the bank, you pay the bills yourself. We ought to treat both choices the same way. Same benefits under the tax law. You put $1 here, it's treated the same way as you put the $1 there. I believe that most spending in the medical marketplace should be by patients, at least at the margin, spending their own money. And when they're doing that, you're going to find that the greatest benefit from the health savings account is not that the patient is more careful, although he will be. The greatest benefit is what happens on the supply side. The most innovative, interesting things that are happening in healthcare today are happening because so many people are spending their own money. The walk-in clinics, there are 1,000 walk-in clinics around the country. You go in CVS Pharmacy, Walmart, the Minute Clinic is the biggest. Why is it called Minute Clinic? Because they know that time is valuable as well as money. Okay, they know you don't want to wait a long time, and so they cut the price in half. They wouldn't do that for Blue Cross. They're doing it because people are spending their own money. Rx.com, first online mail order pharmacy. Competing with local pharmacies, doing that. Why? But again, because people are spending their own money. Walmart itself giving you $10 for your for a 3-month supply of generic drugs. Would it do that for Blue Cross? No. Will it do that for you? Yes. Why? Because they know you're going to spend that money out of your own pocket and they want your business. I could go on and on. the greatest impact of patients controlling the money is that on the supply side, suddenly everybody wakes up and says, hey, we got to compete for that business.
You addressed, from a political perspective, healthcare for Congress versus the U.S. citizen in terms of their healthcare coverage.
Members of Congress are in the same program as all federal employees. It's the Federal Employee Benefit Program. They get a choice of plans once a year. On average, they're looking at about a dozen different plans. The federal government puts up about 75% of the money. The rest they pay out of their own pocket. They want a more expensive plan. They have to pay more out of their own pocket for the more expensive plan. So there's a lot of good features about it. Unfortunately, Obamacare took that model and is going to impose it on the rest of the country. What I don't like about it is in the federal plan, everybody pays the same premium. You know, an 80-year-old pays the same premium as a 20-year-old, 80-year-old retiree who's still in that program. So the sick pay the same as the healthy, and when you have and there's no adjustment. So when you have a program like that, the insurers realize, well, they want to attract the healthy, and they don't want and they want to repel the sick. Let me just spend another minute on this because this is what's going to be in your future. We're going to have these health insurance exchanges, and you're going to find out that the health plans don't want you if you're sick, and they do want you if you're healthy. And let me just remind all of you that I know you've seen on TV, you've seen in the magazines, how the casualty insurers try to get your business, right? There's a black actor, I forget his name, he's standing in front of the town, it's been destroyed by a tornado, and he says it took 30 seconds for this town to be destroyed, and he says you're going to be in good hands, right? And then you see the other casualty insurers the same way. Chubb has this magazine picture of the guy fishing. He's in the canoe. He's about to go over the waterfall, and it says, "Insurance doesn't matter till it matters." Right? What are all these insurance companies saying to you? They're saying to you, "We know insurance isn't important until you have got a problem, and then we're going to be there for you. When the really bad thing happens, we'll be there. That's why you should insure with us." That's the way the casualty insurance market works. For federal employees, in the fall, they have an open season and they get to choose a health plan. How do the health plans advertise to the federal employees? They never talk about the bad things. They never say, you could get AIDS, you could get cancer, you could get heart disease. Why don't they say those things? Because if you have any of those problems, they don't want you. Instead, they show pictures of young, healthy families. And the implicit message is, if you look like the folks in this picture, we want you. You don't look like these people, we're not sure we do, right? We have so screwed up the market for health insurance that it's not real insurance anymore. And we give the insurance companies perverse incentives, just like we give perverse incentives to doctors and patients. And you're about to enter a world in which I was having a conversation earlier with somebody who has a background in the insurance and brokerage business. And he was worried about the fact that all the agents are going to go away. And I said, well, the employers are all going to go away too. And in the past, even today, you have insurance companies that don't want to spend money on you. But you have a protector and a defender. And your protector and defender is your employer. It's your insurance agent. People who help you out in a system that can be kind of brutal at times. What happens when the agents go away and when the employers go away and you're on your own? And now you're in a market where the insurance company doesn't want to spend any money on you. If you're sick, they don't want to keep you in they wish you'd go to some other plan. That's where I think we're headed. And that's very worrisome. That's the real health care other side of the money problems that we've been talking about.
Americans have been accustomed to a healthcare sort of on demand. If you need a heart operation, it can be scheduled very shortly. Other countries with socialized medicine, such as Britain with the NHS and Canada, that doesn't happen. And in fact, Canadians often go down to the States to get their stuff. Can you see, or can you foresee the market kind of compensating for the cultural expectation of Americans in this regard?
Well, yes, in this regard, I think we are going to have a huge waiting problem. And it's going to happen in just 2 years. We're going to insure an additional 32 million people, and if the economic studies are correct, these people will try to double their consumption of health care. Everybody else, all of you, are going to be forced to have more generous coverage than you probably wanted. There's a whole long list of preventive services, primary care, that you're going to have with no deductible, no copayment. Once we force you to have it, you're going to take advantage of it. You're going to go for your general checkup and for your mammogram and other tests. But, so what I'm describing is really a huge increase in demand. There's no change in supply. This happened in Massachusetts. You heard Governor Romney say, you know, we cut the number of uninsured in half. Well, he did. But they didn't create any new doctors. So you had an increase in demand, no change in supply. The wait to see a new doctor in Boston today is more than 2 months. It's longer than any other city in the United States. So even though all these people in Massachusetts have insurance, in a certain sense, they have less access to care than we have here in Dallas. Okay? And that's going to be a problem nationwide. And let me just say one more thing about it. I think that the concierge doctor, how many of you have a concierge doctor? Okay. All right, a few of you. Do you all know what one is? You know, he's a doctor who gives you additional services. You know, same-day service. You talk to him on the phone. He'll email you. A lot of them, you got a problem with the emergency room. He'll come and meet you at the emergency room so you don't wait 19 hours for your care. People, it costs about $1,500 a year to have a concierge doctor. MD VIP does this all over the country. They're owned by P&G. They have a fabulous service. But what you really are buying is access to care. You're buying the ability not to have to do the kind of waiting that you're talking about, because they'll help you with a specialist too. And I think we're going to move, to put it bluntly, to a 2-tiered system. And people who want prompt care are going to pay $1,500 a year and get it on the primary care. And people who don't are going to wait. And I think that's what's in your future. I'll take one more question. Yeah.
Will that lack of supply be partially overcome by the fact that Canadians won't any longer have any incentive to come across the border?
But they will have, and here's why. When the Canadian comes across the border, he's bringing new money. Okay, so let's say I'm Baylor Hospital, and I got all the stuff I have to deal with, and Medicare doesn't pay anything. But here's a Canadian's coming down here, and I'll give him a package price, and that's new money into my budget. So you may find the Canadian is ahead of the line that you're waiting in. And by the way, it works the other way around. They don't like to talk about this, but you probably can go to Canada and get to the head of their line because you're bringing new money into their system. All of you got a brochure from us. Give us, if you want to be invited to our events, we are having Jeb Bush in.
They're on the table on the way out.
Oh, on the table on the way out. Okay. We have a great speaker series. If you'd like to go to luncheons and see public policy discussions, Newt Gingrich is coming, and we've had Clarence Thomas 3 times. But just give us at least an email address and we'll get you invited. Thank you all very much.